Meet Sara, a 27-year-old woman who presents to the emergency department with persistent, troubling headaches that have started to interfere with her daily life. These headaches aren't new, they've been happening most days over the past 4 months and they're gradually getting worse. She says there are no aura or specific triggers, no flashing lights, no zigzags, no strange smells. Let's take a look at her vital signs. Her BMI is 32, which places her in the overweight range. Her blood pressure is a normal 110/70. The pulse is steady at 80 beats per minute, and her temperature is 37.2 Celsius, which is perfectly normal. The physical examination also appears mostly unremarkable until we do a fundoscopy. Here's where it gets interesting. We find bilateral optic disc swelling, known as papilledema, a key sign of raised intracranial pressure. Despite that, her visual acuity remains normal and her CT brain scan shows no abnormalities, so no mass lesion or bleed. A lumbar puncture reveals an opening pressure of 40, which is significantly elevated. Remember, the normal range is about 10 to 25. So what's the most likely diagnosis? I'll give you a minute to think by yourself. Take a moment, review the clues, and try to reason it out. Let's take a look at our options. Cluster headache. Not likely. These usually come in short, intense bursts around one eye and they don't cause papilledema. Migraine? Possibly, but not quite. While migraines can last a while, they don't cause optic disc swelling. Subarachnoid hemorrhage. Highly unlikely. This would present with a sudden, excruciating headache, often described as the worst headache of your life. This has been progressive over months. Space-occupying lesion. We'd consider it, but CT is normal. And although an MRI could pick up smaller lesions, we already have clear signs of raised intracranial pressure with no mass visible. So what are we left with? The most likely diagnosis is idiopathic intracranial hypertension. This is a diagnosis of exclusion, most commonly seen in young overweight women and typically present with chronic progressive headaches, visual disturbances such as blurring, brief vision loss or double vision, papilledema, and an elevated opening pressure on lumbar puncture with no structural brain abnormality. Let's take a closer look at the condition known as idiopathic intracranial hypertension. Idiopathic intracranial hypertension is a condition where the pressure inside the skull is increased, but there is no tumor, bleed, or infection causing it. The term idiopathic means we don't know the exact cause. To understand what goes wrong, let's first review what's normal. The brain is cushioned by a clear fluid called cerebrospinal fluid or CSF. It's produced in the choroid plexus, which flows around the brain and spinal cord and is absorbed back into the bloodstream through arachnoid villi. In a healthy person, the CSF production and reabsorption is balanced and keeps the intracranial pressure stable. In IIH, this balance is disturbed. There's too much CSF or it's not draining properly, but there's no mass or blockage seen on scans. So what could be causing this? First, reduced CSF absorption. The arachnoid villi may not reabsorb CSF effectively, leading to fluid buildup. Secondly, elevated venous sinus pressure. In obese individuals, increased abdominal and chest pressure can reduce brain venous outflow. This can raise pressure in the brain's venous system, impairing CSF drainage. Thirdly, possible metabolic or hormonal influence. Vitamin A metabolism, hormonal imbalances, or obesity-related inflammation may play a role, but the exact mechanism remains under investigation. As pressure builds up in the skull, it presses on surrounding structures. The optic nerves are especially vulnerable, leading to papilledema, which is the swelling of the optic disc. This causes symptoms like headaches, blurred vision, visual obstructions, and sometimes double vision. Despite all this, imaging shows no structural abnormality in the brain, making it a diagnosis of exclusion. If this case got your brain ticking and helped you connect the dots, give it a like, subscribe, and don't forget to hit that bell icon so you never miss a clinical case that could boost your journey to becoming a doctor in Australia. More clinical cases are on the way, so stay tuned.